and call this health subcommittee, public health subcommittee to order. Why don't we rise and have the invocation? Father, thank you for this day you've given to us. We're privileged to be here. May we ever be mindful that we are accountable to our people, accountable to each other here, but most importantly, we're accountable to you. Thank you for enabling us to be here this day. In Jesus' name, amen. Okay, Shelley, roll call, please.
Yes, sir. Mike Dobbins.
Here.
Keith Austin.
Here.
Charlie Bozard. Julia Coates. Here. Tom Bridges.
Here.
Joe Deere. Hayden Duncan. Rex Jordan.
Here.
Darrell Legg.
Here.
Wes Milfire.
Aye.
Roy Bancroft.
Here.
Mary Baker Shaw. Connie. E.O. Smith.
Here.
Denise Taylor. Here. Victoria Vesquez. You go ahead, number.
Honey.
Okay. We have a form.
Great, thank you, Shelley. Yeah, before you, a copy of our minutes from back in February, believe it or not. These minutes were formally approved in Health Committee, I think, in June. So if you disapprove of the minutes, I'm not sure you have an option. They've already been approved. Okay, moving on to committee to reports. We'll start with Ms. Lisa Pivek. Lisa, good morning.
Good morning. This is certainly a new way to communicate, and it's a new normal, I suppose. And so if it pleases the chair, we do have a lot of information to cover today in the last 6 months with our response to COVID, and would like to have share screen if possible. You should also have a presentation in front of you. If that pleases you, we'll go ahead and do that. Is that okay?
Sure, Lisa, go ahead.
Right, so today we're just going to talk briefly about our response to COVID-19. Most of our normal reports are already in the packets every month with the health services report. So any questions about WIC or any of our other programs that are going on, Nelson Mini Rec Center, I'll be happy to field those after the presentation. But next slide, please. Today what we're going to talk about briefly is our public health role in COVID-19. We're going to go over COVID-19 in Oklahoma, COVID-19 in Cherokee Nation, some evidence-based mitigation, and challenges and next steps for Cherokee Nation public health in relationship to COVID-19. Next slide, please. So in the beginning, our role, we've done several things in relationship to public health and COVID-19. We began immediately with assisting with emergency preparedness for health. This might have meant COOP plans for departments. It was preparing how we were going to do staffing, closing things down. If you'll remember back in early March, there was not a great deal of guidance from the national level, so we basically worked with what we could do at that time. All of the public health staff, unless staff were put on administrative leave for other reasons, every bit of public health staff worked through the close down. They either did screening at the complex or screening at one of the other sites. They either did food distribution, and some worked with the Elder Food Project. But they all worked, that includes, and the WIC worked as well, WIC employees worked as well. The Nelson Mini Rec Center, when it was closed, every one of that staff worked in food distribution or in that food project or screening at the complex. We did a lot, we've been doing a lot of assistance with Cherokee Nation departments that might have issues in the beginning with preparation and preparedness, and now with response and dealing with employees that have COVID-19. As you can imagine, our epidemiology team has been extremely busy, and Dr. Van will get into that in just a few minutes, and I'm done going through these few things. The biggest consumption of our time now is case investigation and contact tracing. The majority of public health staff are engaged in one of those two activities right now. Full-time, 7 days a week, very long days, usually 12-hour days at a time. And then we also work in providing public health guidance and collaboration. We have close partnerships with the county health department and work closely with them, Tulsa City County Health Department as well, and other providers of public health throughout the Green Country. Next slide. So as far as epidemiology goes, Dave will get into that, Dr. Gann will get into that in just a minute. But I want to tell you that Dr. David Gann will produce today daily report number 199. He has not missed a day since COVID started and has basically not had a day off in 199 days. He prepares a daily report that covers global, the United States, Oklahoma, Cherokee Nation, hospital capacity, everything that you can think of. He prepares that on a daily basis and disseminates to health leadership teams. We have an epidemiology hotline that the number is in the presentation at the end. And to this date, today, I don't think this includes calls today, and we've probably already had about 10 or 15. We've had 1,407 calls that we respond to individually. We do a daily testing report. We do daily dashboard updates, if you see those on the Cherokee Nation website. The EPI team also does a weekly update for trending. They stay in close contact with the state partners and other partners across the United States and get that weekly update out. They do collaboration with the OSU ECHO project and other projects across eastern Oklahoma, talking to our partners, and they do consultation with community partners as requested for epidemiology. Next slide. So when we started to work on COVID-19 early on, there's an organization called Resolve to Save Lives, and we adopted the strategy of what's called box it in to help us, to get us all working again. And the strategy is pretty simple. It's test widely, isolate all infected people, find everyone who that person was in contact with, and quarantine them for 14 days. Which is, in a nutshell, basically what case investigation and contact tracing is. Next slide. So in case investigation, what we do is that Dr. Gann queries, we get every single positive that comes through here after they've been alerted by their provider or the patient monitoring team. We call them, we do an interview with them, we talk to them about who they may have been around, we determine a date for when they started having symptoms. We go 2 days back and we interview them extensively, get names and numbers of all the contacts that they may have been in contact with in that time period. Next slide. When the work starts, we call every single one of those contacts. We talk to them about the exposure. We quarantine them for 14 days. We send them follow-up materials. We work with them to get them tested at the appropriate time. And we check on them every day for the first 5 days. And depending on how they're doing after that, maybe every other day. And hopefully make sure that they're quarantined. We do have instances where we help provide connection to other resources. So if they need food, transportation, something of that nature, we do that as well. So today, as of this morning, we have conducted 2,094 case investigations. We have followed 3,408 contacts. We started with the very first Cherokee Nation case. We also work closely with the patient monitoring team. The patient monitoring team follows each and every positive case within Cherokee Nation to ensure that they don't need additional medical care and that they have all the instructions they need. And as I mentioned earlier, we address needs for contact, whether that be needs with their employer sometimes, possibly food, possibly contacts with outside sources of something that they may need. And when we first started working with this, we were basically pencil and paper, then we moved to trying to put together some spreadsheets, and now we have gone to an actual software called Salesforce that we're working very closely with right now, that's helping to hopefully make it easier for us to get through the information, make the contacts, start looking at where the contacts are related, and doing a little bit more epidemiology work with the cases that we have in Cherokee Nation. Next slide. We also do public health guidance and collaboration. We get community requests for consults That might be a one-on-one consult with the family. It might be a business. It might be a school. It might be a community group. But we handle those, each and every one, however, in whatever way is best for that particular request. We have weekly Zoom calls with county health departments. There are two administrators for the county health departments that cover the area of Cherokee Nation. We meet with them on Zoom every week, and sometimes in between that time, we have a very good relationship with them. We share information back and forth so that we hopefully have a collaborative response, because we certainly need everybody possible to do the work that's there. We respond to Cherokee Nation Department requests. That might be making sure that an investigation gets done in a quicker manner that they might need, and any other requests that they might have. We have what we call a rapid response team with the county. So if there's an emergency situation that comes up, whether it be something that happens in a community, such as an outbreak, if it's an issue at a school or whatever, we will activate that response team. We'll get on the Zoom call and figure out how best to respond collectively. We still are working, I'm still working particularly with the CDC Tribal Advisory Committee. We have meetings about every other week to discuss the COVID response and other issues at the national level. And one of the things that is kind of exciting for us is that we will be getting a public health associate program person called a PHAP from CDC starting the second week of October that will work with us. And we have lots of COVID-19 projects that we hope to put that person to work with us for. Next slide. So I'm going to turn it over to David, Dr. Dan, right now for a COVID-19 epidemiology overview, and then I'll jump back in at the end for a couple of comments, and then I'll be happy to field all questions.
Thanks, Lisa. So first I want to go over just a little bit about the virus. The novel coronavirus is a respiratory virus that spread primarily through droplets. We have very good research on that. There's some other evidence coming out that possibly it spread through airborne aerosols, but it's not likely that that's a significant contributor to spread of the virus. And then as well as environmental spread through fomites, which is just droplets that are stuck on different surfaces that people might touch, and then they touch their mouth, or their nose, or their eye. So you can review this later, but it's most of our mitigation efforts surround the idea that the virus is primarily spread through droplets. Now, I find this really helpful with policymakers and program directors as they're trying to figure out how to best mitigate spread of the virus in their particular environments. So this is what we call the disease trajectory, and the slide was made by Dr. Jennifer Clark through the OSU ECHO project. If you consider if someone who has COVID-19, the first day they have symptoms is day 0. On average, they've likely been exposed 5 to 6 days before their symptoms first started. So you'll hear people getting exposed and the next day getting tested. It's not likely that if they do have the virus incubating inside of them, that they will, not likely that they will test positive. Now, what's so hard about this virus is that people are contagious 2 to 2.5 days before symptoms start. And the onset of symptoms are generally mild, not 100%. But many of our cases that we work with, it starts out with a runny nose or scratchy throat or headaches, not feeling too well. And so they're not sure if they have COVID-19 or not. And the time of maximum viral shedding occurs on day 0, day 1, and day 2. So as symptoms become more severe. Again, what's so difficult about this virus is that compared to the SARS that we dealt with many years ago, the onset of symptoms was abrupt and very severe, and maximum viral shedding occurred much later. So you're shedding virus before you have symptoms. We have plenty of evidence that people who never develop symptoms spread the virus. Then the onset is generally slow. If you have the virus and you become hospitalized, on average that will occur around day 7. So as we see an increase in cases in Oklahoma, the increase in hospitalizations won't start to show themselves in the data until a week to 10 days later. If you do are unfortunate enough to end up in the intensive care unit, that on average occurs day 10, 11, or 12. We don't really know the immune status of people with COVID-19. We don't know enough about the virus yet to say if someone is immune, and if so, how long they're immune. There's some limited evidence showing that people with milder disease have a milder antibody response, and the antibodies don't stick around in their blood as long as someone who has more severe disease. So this is still, we just don't know. Now, what's most concerning is the data coming out now, the research of the morbidity or the long-term effects of people who survive infection with the coronavirus. Some decent evidence that 1/3 of people who are not hospitalized with coronavirus have long-term effects. Now, we've only known the virus for 9 months or so. We don't know what it's going to be like 2 years from now, 5 years from now, but the World Health Organization and CDC are already preparing for what might be COVID clinics for the long term to help people through these possible long-term effects. But all these body systems can be damaged. We've worked with plenty of patients who have continued fatigue, continued shortness of breath. I worked with a young woman yesterday who for several weeks now has continued numbness and tingling in her extremities. Very healthy young woman. So this is very concerning. It's not just the mortality that we're concerned about, but the longer term morbidity. So in the United States, Oklahoma, this data is a few days old. Now Oklahoma is number 4 instead of number 5. And this is from the Harvard Global Health Institute that reports cases based on the date that they're reported by the state. And then they calculate a rate per 100,000 people in each state. On Monday, Oklahoma was at 27.8. We're now up to near 29. Arkansas is next to us, and right now there are 7 states that are in the red, which is above 25 cases per 100,000. Oklahoma has been in the red for a few days now, and this case rate per 100,000 has been going up for about a week. So here's the daily number of new cases based on the date reported by the state health department. And you can see this dotted line is the 7-day moving average. And for the last 2 weeks now, the number of cases has been going up. We don't have today's data yet, and we'll see how that is. Maybe a little flattening in the last 2 days, but very concerning. This is the same data. This graph is produced by Dr. Jennifer Clark again. But this is the same data, but she includes the black bars that show significant events that would affect the spread of the virus, either to decrease or increase the spread. And you can look at that more later. We won't go to it in detail. But it helps kind of understand when things start to go up, why they might have. Now, this part on September 8th of new reporting, there are several different kinds of tests for COVID-19. The most accurate and the ones that we use at Cherokee Nation Health Services is a PCR that tests for the viral RNA. And it's also called a molecular test, and we can do that in a rapid fashion with a test we call the Abbott test, or a test that we send out to our reference lab, LabCorp. There's also the antigen test, which is a rapid test that looks for the proteins that are on the outside of the virus, and not quite as accurate as the PCR. But previously, the state did not report positive antigen tests as a positive case, and they started doing that by the recommendation of CDC on September the 8th. So that would explain some of the increase in numbers immediately, but this trend is explained by increased spread of the virus in our state. Now, the Oklahoma State Department of Health reports cases a little bit differently. This is from the county alert system that's published once a week, Friday around noon, and it covers the last 7 days. And the state reports the rate of the number of cases per county based on the date of onset of symptoms. So often the data is a little bit behind, and they don't go back retroactively and update the numbers as the weeks march on. So you can see Cherokee County is above 30 here. This is from last week, so we'll get the current numbers tomorrow. Now, with the state's color coding system, you can see here that no county will be in the red until there's a trigger. And those triggers are if the availability of ICU beds falls below 5% in the whole state, or if the number of medical surgical beds falls below 5%, if the availability of personal protective equipment for healthcare workers falls below 5 days. So we don't see any red. In the Harvard Global Health Institute coding system, if a county is above 25, then they're in the red. I have a graph that kind of compares everything. So here's a Harvard Global Health Institute map. This is data through Tuesday by county in Oklahoma. There are 32 counties in Oklahoma that are currently in the red, and that number has been increasing over this week. You can see in northeast Oklahoma, 5 of the counties that include Cherokee Nation are in the red. So here's a comparison of the 4 different maps that are available for Oklahoma. The White House puts out a report once a week that we have access to that's a little outdated by the time we get it. But their color coding system is pretty simple, and it matches somewhat what Oklahoma does, except the White House doesn't have an orange category as you go from green to yellow to red. Oklahoma's been in the red according to the White House, for the last 8 weeks or so. The Oklahoma State Department of Health, we reviewed already. It's 14.39, seems like an odd number for them to pick, but that equals 100 cases per 100,000 per week. You divide that by 7, and the state reports it on a daily number. And then we talked about what makes something red. And the Harvard Global Health Institute we went through, the State Department of Education has used the numbers from this category, the way it's calculated. So with their color coding system, they have 2 orange levels, orange level 1 and orange level 2, and then the green, yellow, and red. And then they have a list of recommendations for schools and counties that are at these different levels. So this is the last map that's available from the State Department of Education. You can see we have 3 counties in orange level 2, several 2 in red, several in orange level 1, and then Mays and Washington are in yellow. A lot of the cases in Craig County are due to a prison outbreak, but otherwise no big outbreaks in northeast Oklahoma that we've identified or that we've heard about. So again, for you to review later, this is from the State Department of Education and their recommendations at different levels of viral activity in the county and recommendations for what schools want to do. These are not requirements. The State Board of Education has said schools can decide on their own how to implement these recommendations. I have a more complete document that explains in detail each color code. If you would like to see that, just let me know. I can pass it on. It's available on their website. So the other metric we use to determine how things are going in Oklahoma is occupied beds for people with COVID-19 or suspected COVID-19, which just means they have a test that's pending. And here's our peak in July and the beginning of August, and things calmed down, and now things are moving back up. And again, this I suspect these numbers will be back near 700 in a week or so, as the increase recently in the number of cases turns into increased number of hospitalizations. Remember the disease trajectory that we reviewed. The state recently started reporting the number of occupied beds in Tulsa, which affects us greatly because there are many patients that are too sick for us to care for, and we try to send those to Tulsa. And if Tulsa fills up and the surrounding hospitals fill up, that's when our health services will be in extremis. We'll have a difficult time. I can tell you several days over the last month, we've had to send patients to Missouri that we couldn't care for because the eastern half of Oklahoma was full and the western half of Arkansas was full, and the closest hospital we could find was Joplin. So we're at the tipping point. 2 or 3 bad days of cases in northeast Oklahoma could overwhelm our hospital system on this side of the state. This is something for you to review more in detail later, but this is a breakdown by age categories, and these numbers show the number of cases through July for each of these age categories. And the percentage point here is the percent of those cases that were hospitalized, the average length of stay in the hospital for those hospitalized, and then a mortality rate to the side. So you can see that this is not a benign disease for the younger kids. 3% of kids age 0 to 4 are hospitalized for an average length of stay of 6 days, but the mortality is 0. And then for 5 to 14 years old, it's 1%, and 1% for 15 to 24. There have been a few deaths, it's just less than 0.0%. And then the hospital rate trends up as age increases, and we get to 75 to 84. 1/3 of those patients are hospitalized for an average length of stay of 10 days, to 8.6 mortality. And this is Oklahoma data. So among Cherokee Nation Health Services patients, there's a breakdown in the chart here of the cases by age group and the deaths that we've been able to find out. So of the 21 deaths that we've been able to investigate and confirm were related to COVID-19, 20 of those were Native Americans, 19 were Cherokee citizens, and 8 were Cherokee speakers. I think there's one more speaker that we haven't investigated yet to confirm that has passed with COVID-19. It's difficult for us to calculate a mortality rate for Cherokee Nation because we know there are citizens who get their care outside of our health services, or they might have tested positive here and gotten sicker and gone to another hospital and might have passed and we don't know about it. So we're vigilant, and we work with our health services registration people who track these and keep an eye on social media. And if we get any word of possible death among a Cherokee citizen, we investigate it with the state and try to confirm what happened. So among the people that we test for COVID-19 at Cherokee Nation Health Services, we've had a total of 2,053 cases as of 8 o'clock this morning. And we have 405 active cases. So about 20% of the total cases we've had are currently contagious. Now, if you look at the daily rate, and this is based on the date of tests, you can see the curve. On the weekends, we don't do nearly as many tests, so the numbers are lower. That's what those dips are. So on Monday, we have an increase. Our 7-day moving average is now above 30. So we're experiencing the most number of cases than we've had throughout the outbreak. This starts to dip down because this 24 is from yesterday, and we still have over 100 tests pending from the test that we did yesterday. And we'll get a few more cases from Tuesday as well. So we hopefully will stay leveled out, not too much higher, because our contact tracing team and our patient monitoring team is stretched to the limits for sure, but we're meeting the need. If you look at the number of cases per week to help smooth things out a little bit, you can see last week that ended on Saturday, we had over 200 cases, which is higher than we've experienced before, and we're on pace this week to match that. No indication that things are getting better yet. When you look at the testing, the number of tests we do, last week we did over 1,700 tests. The week before, the number is lower because we had a 4-day week, and we don't do nearly as much testing on the weekends or on the holiday. And we're continuing to find ways to increase the availability of testing. but we're limited by staff. We seem to have adequate supplies to meet the current demand, but also to educate the public when you should get tested, how to get tested, and what our criteria are for testing people. So we do need to increase the number of tests we do. Right now we're averaging at about 250 tests per day. And here's the weekends, as I mentioned. You can see on Monday the increased number of tests, which results in an increased number of cases for us to investigate. That kind of pulled over from the weekend. So we're staying steady on days like Tuesday where there was rain, we have fewer tests. And we see that quite often, the number of tests affected by the weather. Test positive rate is always something we watch. The good body of evidence from prior to COVID-19 outbreaks show that during an infectious disease outbreak, if your test positive rate is more than 10%, then you're not casting a broad enough net to capture all the cases that are out there. It indicates widespread community transmission of the virus, and also it limits the effectiveness of contact tracing and isolating people who test positive because we're not able to find them all. So the solution to this is to increase the availability of testing and increase the communication with the public on how to get tested and when to get tested. So you can see for the last 2 months we've been over 10%. Now this is somewhat isolated, right? This is just Cherokee Nation Health Services. We don't have test positive rate at the county level to include the state's data. They don't provide that data. It's not available. So this is the best we can do, but we do need to do more testing. Now, if you haven't seen the Cherokee Nation dashboard, the Epi team updates this daily by noon, and this is the number of cases per day per 100,000 people, 7-day moving average, just like the Harvard Global Health Institute method. It's the same age categorization, a color scheme that we use that the Harvard scientists developed. Again, you can see 5 of our counties are in the red, and then orange, and Washington County is yellow. And this is through the state data we received yesterday morning. We haven't received today's data yet from the state. Every county is increasing except Tulsa and Washington. I think Mays was steady over the last couple of days, but every other county, the numbers are moving up every day for the last week. So very concerning. Cherokee County has uncontrolled transmission. Adair did well for a couple of weeks and are now heating up in Sequoia County as well. I mentioned they had the outbreak in Veneta at the Department of Corrections facility there. In Ottawa, I don't know what's happening for real. The case investigations that we've done over the last 2 weeks show that most of the transmission is community spread. It's from small events, family dinners, get-togethers, maybe a small wedding, baby shower, and then we've had some somewhat larger events, some sports teams, and some weddings and funerals. Funerals are high risk for super spreader event at funerals.
Dr. Gann?
These risk reduction methods that we have, these mitigation methods, they do work, right? If they didn't work, our hospital and all of our clinics would be closed because this is what is protecting our Cherokee Nation government and our whole healthcare system is masking, washing hands, and distance.
Hey, Dr. Gann, can you hear me?
Yeah.
Yes, sir. Could you pause for a second? I just wanted to give our subcommittee members chances to ask questions. You provided us with a lot of data up to this point.
I did.
Would you be receptive to some questions at this point? Can you hear me? Can you hear me, Dr. Gann?
Yes, sir. Yes, so I'd be glad to take some questions.
Okay. Floor is open. Who has questions up to this point? Wes?
Dr. Gann, well, let's see, where are we getting our numbers from? I see that we were using CDC guidelines or tracking numbers, and now we have the Harvard Health Institute that's been thrown out there. Are those two different reports, or are they the same group? I don't know where we're getting our numbers from or who to look to for numbers. Are we looking for CDC reports, or are we looking for Harvard Health Institute support?
Right. So the data that we use comes from the Oklahoma State Department of Health, and the numbers that the Harvard Global Health Institute works are the exact same numbers. So we are getting the match from the Harvard Global Health Institute are the same numbers that we use, and it's produced by the state on a daily basis.
Is there a reason why we're using them instead of the CDC?
CDC doesn't report numbers to us, the number of cases, and all the numbers that the CDC has comes from the state. So CDC doesn't collect numbers independently. The only thing that's different is the way the state reports the daily number of cases on their maps is based on the date of onset of symptoms, not based on the date reported. So they send us the daily numbers on the date of report, but they translate those, they go into their state reporting system and look for the date of the onset of symptoms, and that's where the day that person is put as a new case. Where for the Harvard Global Health Institute and the data that we use, if there's 1,000 cases reported today, then they're all reported for September the 24th. Now, and if a person is asymptomatic and tests positive, then the state uses the date of test as the date of onset of disease.
Okay, yeah, I just want to make sure that we're reporting the right numbers to our citizens,
Yeah.
so there's no confusion. Because I know the director of the Harvard Global Health Institute has been very advocating against the CDC. So I just want to make sure that there's not any political confusion on which numbers we're sending to our citizens.
No, I think the other data, when you get more granular, when you start looking at the presence of chronic diseases in people and hospital bed capacity and treatments, those data all that gets sent to CDC and it gets crunched and they come out with some other stuff. But this is positive tests. That's what we're talking about. So it's pretty simple data. There's different color coding schemes, but everyone's reporting the 7-day moving average of daily cases. But the White House just, instead of doing a daily average, they just do the last week. They add them all up. So it's not too hard. It's the color coding schemes that are confusing, and that's why I put that chart in there earlier that has the 4 different schemes. They're the same numbers, right? They just have different cutoffs. So yeah, it can be very confusing. We try to be consistent here. In my daily reports, it's the same graphs over and over and over. Our dashboard is the same data over and over. The important thing really is the trend, right? If you think that, well, these tests are too sensitive or these tests aren't sensitive enough, if we're using the same tests and we can watch the trends, we know if the virus is increasing or decreasing. So if I tell you that the 7-day moving average of daily new cases in Cherokee County is 38, that doesn't mean anything in reality to the average person. But if I tell you that it's doubled in the last month, and I know 2 friends who have had COVID-19, and right now we have 14 patients admitted to Hastings Hospital with COVID-19, and 2 weeks ago we had 5, right? So all these indicators are saying that there's viral transmission in our community. It's increasing and it's concerning, and we should do something about it. I think that's really the most concerning now with what we're seeing in the state over the last 2 weeks with the number of cases. There have been no new public health or other mitigation measures instituted, and I haven't heard plans to do anything different than what we're currently doing, which means I don't know where the peak is. I don't know what's going to slow it down. I'm sorry, was that?
Yeah, I was just trying to get through the confusing aspect of a government reporting on COVID cases and then a private institution that speaks against the government's reporting method. That was all I was just trying to get is which one we're reporting to advise our government.
Okay,
Yeah, and we kind of look at, if you will, an industry standard. What are most people using, and what's the general consensus on the best way to look at the spread of the virus from an epidemiologic point of view?
Okay.
So,
All right, appreciate it. Appreciate your
On that one slide there, you said the weather affects the results? What do you mean by that? How does the weather affect it?
The weather affects the number of people who get tested. So on Tuesday, when it was so rainy, people are less likely to get in their car and come through our drive-throughs. So I was talking about this Tuesday of this week where we had rain all day long. The number of tests was less. And so the number of cases that we have to investigate will decrease, but that'll generally pick up the next day. So there's that they're never going to get tested. But if you look at a day-to-day moving average of number of cases, it's affected by the number of tests we do, and the weather will affect that.
Okay, I was taking it the other way.
Speaker?
Yes, sir. Dr. Gann, do we have data on school-age children, maybe high school, 9th grade through 12th grade, since the opening of the schools? And now we've got Labor Day over with, and we have the floating season on a river. That's passed now. I figure that's part of the reason some of our numbers are up here in Cherokee County. Do we have any numbers about our high school kids, Hulbert, Keys, Tahlequah, Sequoia, that's opened back up, where some of the kids where it's been fatal, that's gone through our school system? Do we have any numbers like that?
We do. I don't have them available for the slideshow, but I'll get them to you. And we did take a deep dive a couple of weeks ago looking at just our health system and the number of tests we've done for that 5 to 17-year age group and the number of cases we had. And we haven't updated that in about 2 weeks, but the number of kids getting tested increased and the number of cases also increased. What's really hard is determining where the kids pick up the virus.
Right.
Because there's so many opportunities to become infected. But sometimes it's obvious, right? If you have a wedding and there's 200 people there and 50 of them test positive, then you kind of assume that they were exposed at the wedding. But it's still just an assumption. We could have easily picked it up in other places. And today, specifically in Cherokee County and Sequoia and up north, there's so much virus everywhere. If you're with someone who doesn't live in your house with you, there's a significant risk of being exposed to the virus. So that's the way it is.
Okay. Thank you, sir.
We'll get some numbers on the kids.
Okay. Thank you, Mr. Chair.
Sure. Other questions? Okay, go ahead and proceed on with your program there, Dr. Gann.
Yes, sir. Thank you. So, the mitigation efforts we talked about, and you heard me say it, if you're with someone who doesn't live in your house with you, mask and distance and wash your hands. It works. And this is the only armor we have against this virus. It really is. Now, the big question now is vaccine, right? I'm convinced with the way things are going in Oklahoma and the United States, we're not going to start to approach normal until we have herd immunity. You've got to read about it. Herd immunity is when enough people in the population are immune that the virus has a very difficult time to spread. And the numbers range from 60 to 70%. In our meeting with Dr. Burks a month ago, where the tribes were invited to meet with her, she said a very powerful statement for someone who's done this for 25 years, is that natural herd immunity, meaning without a vaccine for COVID-19, that path goes straight through the morgue, right? It would, the cost would be too high. So the key is going to be a vaccine. So the question is, when will I get vaccinated? When your constituents ask you, when am I going to get vaccinated? It's difficult to say, of course, right? Right now we don't have a vaccine. But a really nice article from The Lancet, which is a top-tier medical journal, peer-reviewed. There's a nice piece about this question exactly. So the three things we need to get through. Number one, we need a safe and effective vaccine that's been fully studied and vetted by the scientists. That doesn't happen. It won't happen. I'm very concerned that the vaccine will be pushed out early. The history of the last 100 years since we figured out vaccination, there's a whole list of missteps with vaccines where they're pushed out too early, not appropriately studied, and people were hurt. and people die. So we need to be careful and wait for the FDA and independent groups to say this is safe and effective. My litmus test is when Dr. Fauci gets the vaccine, then I'll be able to support it. Secondly, is we need a consistent public health message. What's hurt us through this whole epidemic is different messages coming from different areas, from our state government, from the White House, from CDC, and from NIH, when they just don't match up. And it confuses people, and they don't know what to do. They don't know where the truth lies. So when the vaccine is available, people have to put their heads together, and the message has to be consistent. Then the third part is a system to deliver this vaccine. It appears that the vaccine will require 2 doses. We don't know yet, but likely. And that's just for the United States. We need at least 200 million people to get vaccinated. So that's 2 doses a month apart for us to start to approach herd immunity. And it also looks like this vaccine will have to be frozen before it gets to the point of administration. So the cold chain, there's a lot of logistics to take care of. I think our flu vaccination drive now is helping us take a close look at the systems locally and statewide, and strengthening our bridges with the state health department on the way we do this. And there's going to be a part of the new vaccine that will require prioritization. Who should get it first? And first responders and essential workers, school teachers, healthcare workers will likely be at the top of the list. My estimate for us to be at herd immunity in the United States would be, I don't know, if we're lucky, in the middle of next summer. What happens between now and then is the decisions that we make as communities on how we're going to fight this virus and get things under control. Right now, it is out of control. All right, so Lisa's going to come up next. If you have any questions for me now, that would be fine.
I just have a few comments because I know there'll be some questions, but things that I want to mention about challenges and next steps, and Dr. Kim covered a lot of that. First thing is this is a new virus, and we're watching science unfold in front of our eyes. Scientific discovery leads to changes in how we deal with the virus, what we know about the virus. So the things we know now, we will learn more and more as time goes on. Dr. Gann also mentioned that it's been very hard to put out a consistent public health message because there is a lack of a national strategy of how to deal with this virus. I compare it to if we were being attacked by a foreign army and we were told every state figure out how you want to defend yourself, and then every county to figure out how you want to defend yourself. It's kind of how we're going about this. There's tons of false information on social media, and unfortunately, we have tons of armchair epidemiologists now who come up with theories that are not peer-reviewed science. The lack of a national public health infrastructure is nothing new. That has been happening for the past 25 years, and this virus has shown the lack of public health staffing across the United States. And as we continue to adjust to the virus and the virus trending, figuring out what to do, how to combat it, what we do next, how we manage, trying to get back to some normalcy in our communities. And unfortunately, the cool weather is going to take away the one thing that is helping some, which is outdoor activities. And when we start to get indoor and more crowded, we're probably going to see, logic tells you you're going to see more spread. And then we're also looking at vaccine and preparing for the distribution. Our whole health service division is looking for that. And the only other comment I have about testing is that, we have a lot of testing available. It's about getting people tested at the right time, too. And then being able to find those populations who may be hesitant or apprehensive about getting tested and making sure that we have ways to address that. And now I'm happy to take any questions.
Lisa, this is Counselor Dobbins. I think it's universally accepted that physical activity is important, even when one has the exposed to the virus. In some sense, physical activity is good, done safely. I was wondering, are we going to be able to quantitatively measure the side effects, the damages that with our Sequoia High School students' extracurricular activities, since they can't partake of that? That's going to take that away. Is there a way we can measure the effect that has on them in the event that we have a future similar situation where we have these measures that we can say, well, this is what happened to them with this exposure? Do we have a way, or can we measure the side effects that that might have on our Sequoia students that participate in extracurricular activities?
I don't really know how we would do that from a scientific perspective. That involves a lot of human subjects research. But I will tell you that I've been able to run every day during the virus. I've been able to get out and do things, and I don't think that students are prohibited from getting out and exercising. It's sponsored by parents or endorsed by parents, and so what we do is we adjust the best that we can. So an answer to that might be that there probably would be a retrospective on a national level looking at consequences of what happened during the virus response. I wouldn't look for that for a couple of years. But what I would say about it is that something I forgot to mention is that chronic disease makes our population more vulnerable. And we went into this with high rates of chronic disease, things that we could have been addressing prior and need to. We need to address the health of our population. It made us more susceptible, and it will continue to make us more susceptible to things in the future. And that's the long game, looking at things from a long game perspective. So I hope that answers your question. I think anything, if you're going to target in on Sequoia and specific students, you're into some heavy, super research, human subject research that would have significant problems getting through any approval board.
Okay. Do you have any other questions? Councilor Austin?
Early in your presentation, you talked about the forms of transmission, aerosol being the highest, and surface transmission coming way down in concern, I believe, is what I'm understanding. Do we have an idea of the percent of people who've been infected through touch transmission, surface?
We really don't. It's so the highest risk of transmission is through droplets. Right? So the droplets you picture, and you might have seen the movies. They're larger than the aerosols, and they can travel no more than 6 feet, depending on all the environment. But when someone is at work and they get infected, to figure out if it was because they touched a doorknob and touched their eyes, or if it was from the droplets, or if it was from aerosols. It's really hard to tell. So we can't do laboratory studies and expose people to this virus when we don't have a really well-proven treatment. It's too deadly. So now we've done environmental testing in Cherokee Nation where we find the virus on doorknobs and microwave handles and coffee pot handles, but we don't have any research to show that that's what infected the person. Based on what we do know, majority of transmission is through droplets, and that's why mask or distance are so effective.
Do we know how long it lives on surface?
The one study I've seen looked at 4 or 5 different surfaces, and this was back in May, and it varies greatly from a few hours to more than a day. They have a pretty good idea of how to clean a surface, but and I think most important is how easily is a surface cleaned. Like a couch is harder to disinfect than a stainless steel table, right? So washing hands often, avoiding touching the face, and wiping down often touched surfaces is the best we can do.
Thank you.
Yes, sir.
Any other questions? Wes?
Yeah, I've kind of been putting the crosshairs on this one and dealing with Sequoia High School. I know we have a lot of advice from our public health officials on how we should go about handling our own school. You know, there was several different suggestions to go about it. And as we've seen, a lot of the public schools, or in fact all the public schools, decided to do optional in-class and virtual learning. And that wasn't given as an opportunity to the school, and there has been some complications from it. And from a public health standpoint, I would like to know as far as what your take is on it. I do think that for 8 hours, we can really protect those kids and giving them and being smart about it, because we're able to require them to social distance, require them to wear masks, and daily they're getting their temperature checked. So if we're looking to try to protect a spread, we could keep them in that pod at the high school and continually check them, monitor them, and protect them, and that would also help protect those communities from the spread if we're able to catch it and keep it from going anywhere else. Currently, since they're not able to do that, you know, those kids can expose themselves elsewhere for those 8 hours instead of having that option to be in school. And some, you know, are obviously it works for some families. It's just that for some families it's not. And I worry about the risk of exposure that those kids could have by, you know, not coming to school and being protected that way.
So, you know, we advise the chief and his staff and the school administrators on the risk and benefits. You know, if you look at the recommendations from the State Department of Education, all their recommendations are really based on, depend on the amount of virus in the community. Let me say that. And you really have to look individually at each school district. I think the chief's decision was the right one, and the superintendent on how to deal with it. You know, we balance three things, right? The health and safety of the kids in the community, their parents and their grandparents. And that stretches out for us, that's the health of the Cherokee people, right? And if you congregate students together, the virus is going to spread. You know, the mitigation measures aren't perfect. Just like wearing a seatbelt doesn't mean 100% you wouldn't die in a car wreck. This decreases the risk. And the second thing we balance is what we call in public health social justice, right? Kids have a right to an education. And we know that vulnerable kids, that virtual learning is not as good as in-face learning, and that more vulnerable kids will suffer more. So the impetus is if you're going to go virtual, those kids have to be supported. And I think the chief and the tribe in Sequoia High School has done that. I've talked to a few staff members this week, and they're really pleased with the progress of the students with their education. And the third thing is community, and especially in rural communities, the schools can be the foundation, and really important part of the fabric of the community. So both the extracurriculars and the education and the relationship between the teachers and the parents and all of that's important. So anything that affects the schools affects the whole community. So as the superintendent and as our chief tries to balance all of these, you try to make a decision, right? And I think what the chief has done was fully supported, was very reasonable, but then it puts the burden on Cherokee Nation to take care of those kids and those families. And like I said, the feedback I've had from administrators and teachers at Sequoia is it stinks, but they're doing everything they can for the kids, and the kids seem to be doing well, generally.
Kind of contradict that. I've getting a lot of phone calls with a lot of transfers out and struggles, and of course this is not an education committee meeting, and I understand that it's public health committee, so I'm trying not to go too much into education, but they do kind of coincide. What was our recommendations for the Cherokee Nation Development Program, our Indian Capital VOTEC, Cherokee Nation Surgical Tech School, OSU Medical School? Those are all still open. Why had we advised only Sequoia High School to not have that in option if we're trying to protect everybody? I just didn't know if there was some sort of reason particularly why that entity of our education department was advised to go virtually only?
I'll take that one, Dr. Dan.
Sure.
Let me make it clear. We do not make recommendations that you open and close. We do not make those kinds of recommendations. We told, as Dr. Dan said, we give you the risk-benefit analysis to look at. We give you the facts to weigh the information and decide what you want to do and how much mitigation you're able to put in place. We do not recommend that you open or close. And let me make that clear. We do not make that decision. While I still fully support the administration and Chuck Hoskin's decisions, we do not make decisions for schools. That is up to the school administration.
Okay, just making clear. I know you guys were advising them on that, and just was kind of curious as to how we got led in that direction. Appreciate it, Speaker. Appreciate it, Chair. Sorry.
Dr. Gann, Chief of Staff has approached the podium. Go ahead, Chief of Staff.
If I may, Public Health has tried to work with all of our public school systems that will listen. They've worked with NSU, they've worked with Rogers State. Anybody that has reached out to them, they've tried to provide them the guidance and the information in an unbiased way that they possibly can. They try to be understanding and accommodating and trying to help the schools make the best decision that they have at that point in time. They work with superintendents, they work with school boards, and although they've made those recommendations, we don't control Indian Capital Tech, we don't control OSU. They operate their own schools and their own systems, and while they may be partners, they do make their own decisions. Been up since 3 o'clock today because I knew today was going to be a very challenging day between our students that want to get back into class, and I respect that 100%. But it boils down to essentially the Oklahoma State School Board Association has provided guidance and recommendations to every school district in this Cherokee County in particular, that based on the number of positive cases that we have, for us to try and control the spread and get back to a sense of normalcy, we should be doing virtual learning. The analysis I would like to provide to you is this is going to be the wave of our future. This is transforming the way we work at Cherokee Nation. It's going to transform the way banks work. It's going to transform the way schools and higher education institutions, although they've already been doing virtual learning, institutions are going to be doing it more. Our operators that operate the phones, not a single one of them sits inside this complex today. Most don't have a high school diploma. They have a GED. They are fluent speakers, and we want to protect them and keep them home, but they can still do their job. And so those individuals are sitting in their homes, remoting in through VPN technology with MiFis, logging into a virtual console, and answering the phone calls and transferring to departments or individuals that may not even be in the office right now, trying to protect them. So I use that as an example is we really need to try and embrace this virtual learning. It is going to be something that if the students do choose to go into college, they're going to be exposed to it. They're going to have to adapt to it. And even if they choose to enter the workforce, this is going to be the way that we operate, such as our operators and most of our staff right now are working virtually. And so I think in our best interest that we try to work together to come up with a solution that's the best for our citizens, and we work to mitigate the impact of the virus in our communities as much as we possibly can, so we can get back to a sense of normalcy. I was hopeful a few weeks ago when our numbers started to trend downward, and I thought we might see a turn and things might be going in the right direction. But we knew that schools were opening, and we also knew that Labor Day was right around the corner. And unfortunately, the numbers are actually going up because of those instances. And right now, Dr. Gann, is it 4 or 5 of the 14 counties? It's 5, correct? Ottawa, Craig, Cherokee, Adair, and Sequoia counties are all in
Yes, sir.
the red status based on that. So I'm a little emotional about this because Dr. Gant presented today that we know that we've lost 8 and maybe a 9th speaker. And Howard Payton is the new executive director of our language department, and he is doing everything he can to help preserve the language. And our reaction to COVID in the communities is removing some of those speakers that we won't get the opportunity to share another day with, to learn from, and to help preserve the language. And that, I told Howard the other day, I felt like this virus has, even though he had one hand tied behind his back trying to help promote the language, now we've tied the other hand behind the back and threw him in the water. And time is of the essence, and as much stuff as we're trying to do to preserve the language, I think this is one other thing that we really must do, is to protect those elders. Because we don't, I'm afraid we're going to see 3 more this week that are in bad shape that we won't get back. So thank you for that time, sir.
Okay, thank you, Chief of Staff. Thank you, Dr. Gann. Thank you, Ms. Pivek, for sharing with us. I know you'll be open to follow-up phone calls if we have questions. Correct?
Absolutely.
Okay, any other?
One quick statement. I just wanted to bring it to everyone's attention. I know these masks, they're beautiful masks. In fact, I see a counselor wearing one right now. They were handed out for a Cherokee National holiday, and I've seen a lot of people wearing them, but I noticed that there was an email sent out by Dr. Steve Jones that these don't protect against the spread of airborne illnesses and that they're advising people to wear a mask underneath them. So I don't know if that's something that we want to take up with the public health department to make sure that we can get that information out there. I know it's been handed around, and I've seen a lot of people wearing them. I just want to make sure that we are okay with knowing and letting people know that that's the case with those masks.
Wow.
That email was directly sent to health employees in a clinical environment. In a clinical environment, we do not allow our medical team to wear fabric-based masks. Guidance from the CDC and other folks indicate that a multi-layered cloth mask does provide some protection. Is that my favorite mask of all the ones that I've worn and used? No. But it does provide some protection. But that email that Dr. Jones sent was specifically directed at our clinical healthcare environment where we have to have heightened protection. But individual citizens roaming around the communities, as long as they are wearing a multi-layered cloth mask. I don't recommend bandanas because they're single layered. But if you have a multi-layered mask, the more layers, the better off you are. If you wear a surgical mask, such as what Mary Baker Shaw, E.O. Smith, and Darrell Legg are wearing, those provide better protection. And the best protection we have at this point in the United States is an N95. And so many of these fabric-based masks, like I'm wearing right now, have an N95 or a PM2.5 insert that can be added into that as well. So hopefully that clears that up. But that email is specifically directed at our healthcare employees in the clinical environment.
Okay, any other comments? I see no old business, no new business. Any announcements? There is one. Next meeting's Tuesday, November the 17th at 9 a.m. I would entertain a motion to adjourn. Second? Good.